And our last speaker is Prakruti Rao from University of Virginia, United States. She's got up very early today, and she's going to talk about urine analysis with a smartphone to facilitate TDM in remote setting. And she holds a bachelor degree in biotechnology from India and a master in clinical pharmacology from the Ohio State University. She's part of a team that tests feasibility of using urine to perform TDM in tuberculosis patients through non-invasive methods. Her focus involves performing pharmacokinetic modeling and simulation in unique TB datasets to determine optimum treatment regimens. Prakruti, if you're here, yes. Welcome. Yes.
Thanks.
Thanks for the introduction.
And thanks for the introduction, Dr. Altenar.
Please start your presentation.
Yes. I'm going to turn off my video because just to save on bandwidth because my internet is a bit slow today. Are you all able to see my screen?
Yes, thank you.
Great, thank you. Thanks everyone for the participation. I know it's a bit late for a lot of people, but just wanted to thank you for the participation and thank Dr. Altenar and Dr. Parker for inviting us here. So my topic for today is urine analysis with smartphone to facilitate TDM in a remote setting. I have no conflict of interest to disclose, and a lot of our previous speakers, they discussed about using DBS or saliva, and then I wanted to discuss initially what the appeal to use urine for TDM is. And like DBS and saliva, urine uses minimal pre-processing and like serum, which needs to be stored in a freezer right away because TB drugs like rifampin and isoniazid, they degrade very quickly, and once serum is collected from whole blood, serum or plasma, they need to be stored and they need to be frozen right away, and then we don't have to do that for urine. It's just refrigerated and it can stay good for at least 24 hours, and we freeze urine afterwards. So there's minimal pre-processing. It's just making aliquots. We don't have to use the centrifuge. We don't have to do any of that. It's just making aliquots and then freezing. So it's easy sample collection and storage, which is more acceptable in pediatric populations. And in the study we did, it also involves pediatric patients, which I'm going to discuss in a little bit. And urine colorimetry, which is what is commonly used, it uses simple laboratory procedures. It doesn't use HPLC just yet. It can, of course, we can also use HPLC to quantify drug concentrations, but more commonly it's either colorimetry or visual detection that's been used. And especially for isoniazid, it's been used for over 5 decades, and even the procedure that I'll discuss today, it's called the Sunnah Method for determining rifampin. Even that was published in the 70s, so it's been around for quite a while. So anyway, getting to our study. So what we did was we tried to take it a step further. Instead of using the spectrophotometer, which we normally do, we tried to see if we could do something even more point of care, even that's easier to perform. So all the patients of this study were all outpatients, so they were still in the intensive phase, but they were outpatients, and they were recruited. They were part of a larger pharmacokinetic study, and they were recruited at Haydn Lutheran Hospital, which is in rural Tanzania. And for this study, we picked a convenient sample of 12 pediatric urine samples, just to make sure that we picked a few who had high serum rifampin concentrations, some who had medium, and then some who had a few of the lower concentrations, just to check the validity of the assay. And the patients provided a 2-hour spot urine sample, but the serum blood was collected at 1 to 6 hours after the medication dose. And the serum was measured using HPLC, and which was then used to calculate area under the curve. Just some demographic characteristics of the 12 samples. The median age was 3 years, and 5 of the 12 patients were female, and the median rifampicin dose was 12.7 milligram per kg, and only half of the 12 of the selected samples had a serum concentration of more than 8 milligram per liter, which is what we expect to see as the minimum threshold, and 45% had an AUC of 0 to 24 hours greater than 35 milligram per liter. And the image you see on the right bottom, that's a 3D printed light box that we designed collaborating with University of Virginia's engineering department, just to provide different places might have different lighting, so this is just to standardize how much light the samples get. So we designed a 3D print, custom made 3D printed box, and we were able to measure the absorbance using just a mobile phone. We didn't even need a spectrophotometer for this proof of concept study. So the name of the app that we used was Colorimeter RGB. It's an Android and an iPhone app. It's not free, but it can be bought with it's just minimally priced. So what we did was after serum was collected, and so it was a bit of a challenge to ship all the samples here, because we couldn't, as other speakers pointed out, it's not easy to perform TDM in remote settings, especially in Tanzania, and Hiram is a very rural part of Tanzania, so we had to ship all the serum, urine, and all the samples all the way to America. So afterwards, we had HPLC done on the serum, and then we did both spectrophotometry and mobile phone light box for the urine, just to compare, just to see how light box compares with the spectrophotometer. So the methodology we followed here was the Sunnah Method. It's very easy, it's simple, and it only uses 2 chemicals. It's just a buffer and a solvent, and you take the extract and read it in a spectrophotometer. So we first did that. We read the urine, the extract in the spectrophotometer, and then we took the extract and put it in the light box that's here, and then you use the app, and then it takes a picture, and afterwards it tries to match it with a similar color, and then it gives you the absorbance. So what we did was we plotted the absorbance of the mobile phone with rifampin Cmax, and then we again plotted the absorbance with the AUC over 24 hours for both the mobile phone and the spectrophotometer, just to see how they both compared with the serum parameters. And it seemed like the correlation was pretty good, and especially for the Cmax, while comparing with Cmax values, we can also observe that the correlation values are pretty close to each other. Maybe not so much for AUC, but definitely for Cmax. And our hypothesis is that it's higher, the correlation value is higher for Cmax, because the urine was a spot sample collected at 2 hours, and it was not something that was collected over a long time, whereas serum was collected at 3 points until 6 hours after dose. And then there are some more analyses that we performed, and ROC curve, receiver operating characteristic curve, was what we did with the light box absorbance and serum values, and the AUC under the ROC curve was 80% for the Cmax, and it was 76% for AUC over 24 hours, and the sensitivity for both Cmax and AUC over 24 hours was 100%, which means that it detected all samples that had a serum threshold below 8 milligram per liter or 35 milligram per hour per liter. And then we also tried to compare if the median median absorbance of the mobile phone reading and the serum parameters, and then the median absorbance of any of the samples that had Cmax target above 8 milligram per liter had a higher median versus a sample that had a lower serum target value. So in conclusion, for just this study, it's still a proof of concept, but it tries to bring colorimetry one step closer. And the purpose for just trying out this light box was that initially we had difficulty even getting a spectrophotometer shipped to Tanzania. So they weren't able to buy one themselves. So we had to buy it from Virginia and then ship it all the way to Tanzania. And even shipping is a bit challenging because there are only a few companies that ship equipment or samples, maybe even dry ice shipments. So our goal was to do something even work on something that's definitely point of care and also that's even something easier rather than doing HPLC, because it needs trained personnel to operate the machinery. And urine colorimetry, with a bit of with training, anyone would be able to perform colorimetry. And then I wanted to discuss a few similar proof of concept urine colorimetry studies for pyrazinamide and levofloxacin. So the pyrazinamide study was done by our collaborator, and they had a derivative study and a validation study. And then in their validation study, they found that the spectrophotometric assay using urine, which was also for a spot sample, was 97% sensitive in detecting pharmacokinetic target attainment of 363 milligram hour per liter. And then, so again, all of these samples are just spot samples, and then hydration status and how much water they drink, or if they have other renal dysfunction, all of those factors might influence how much drug is excreted in the urine. So we wanted to determine if we could do a pooled sample, instead of just collecting spot samples, we wanted to collect a sample over a period of time, say 24 hours, and then see how it compared with serum. So in this study where we tested levofloxacin, so just a side note, levofloxacin is almost fully eliminated by urine. So this was kind of a good study to start testing how it compared with serum. So there were 6 volunteers, 6 healthy volunteers, and then we then recruited 10 patients living with 10 MDR-TB patients living with HIV. So for the 6 healthy volunteers, they were just given one 750 milligram dose of levofloxacin, and then urine was collected over 24 hours. So they were collected in 0 to 4 hour time interval, 4 to 8, and then 8 to 24 hours after dose administration. And serum blood was collected before dose, and then at 1, 2, and 6 hours after medication. And then in healthy volunteers, which is the plot on the left, so the highest correlation was between the 4 and 8 hour collection interval, and with a correlation coefficient of 0.9. And then with the serum AUC instead of Cmax. And then on the right is for patients with MDR-TB, and then their highest correlation was at 0.4 hour collection interval. So we didn't actually observe a similar collection interval that fared well for both. So it was a completely different collection interval. So then we decided, like, how do we standardize such differences? So we could do that by enrolling diverse study population, and then also doing paired urine and plasma sampling for full pharmacokinetic curve. So all the serum samples that were collected either stopped at 6 hours or 8 hours. So we didn't collect serum until 24 hours. So the way to move forward would be to collect for 24 hours and then validate the urine assays in different labs. So the urine assay that we did initially for the mobile phone light box was done in Virginia and not in Tanzania. So to check the validity of urine assays, we wanted to make sure all our partners would be able to work on the assay in their location, because that's essentially the goal. Our goal is to improve TDM in remote settings, so it really makes no sense if they just ship all the samples here and if a different country works on it. So our goal is to make sure that we increase the capacity and training of people, of laboratory personnel in Tanzania to run the assays themselves, and also determine find out if there's just one value that we can find out. If, let's say, the urine at a urine interval of 4 to 8 hours, the rifampin concentration is 50 milligram per liter. Does that mean that the person is having enough serum exposure? So is there just one value that we could use that indicates adequate serum exposure? So right now we are working on a prospective study, observational study. It's a point of care evaluation of exposure to TB drugs, which we fondly refer to as PTB. It's funded by the NIH. And we're just finished recruiting, and we're still working on data analysis. So we have recruited 60 adults with TB in the state of Virginia and state of New Jersey in America. And we have enrolled 90 children, 90 pediatric patients with TB in Haydn, Tanzania. We collect a serum before dose. So there are patients who are smear negative but are still on intensive phase. And blood is collected at 0, 1, 2, 4, 6, and 8 hours. So the 24-hour that's here is just for the urine, it's not for blood. So serum is collected only between 0 and 8 hours, but urine is collected from 0 to 4 hours, and then 4 to 8, and then 8 to 24 hours. That way we can quantify the drugs in the entire 24-hour interval. So this is really we are trying to do it point of care. So right now, Tanzania has the capacity to perform urine assays on their own, and they're working on the urine assays, while in America we are working on our urine assays, and we are even trying to cross-check with by getting some samples from Tanzania to here. That way we can see if we can check the validity of the assay, and this is also done in outpatients. So they just come in. It's during, if they have a follow-up visit, they just come in, but they still have to spend the entire day in the clinic to undergo serum collection for 8 hours, and then they bring back a urine. We send them home with a urine container after the 8-hour collection, and then they bring back the urine the next day after 24 hours. So our goal with this study is to find out if there's a particular interval that we can that reflects the serum targets effectively. So the participants don't have to spend an entire day in clinic, because a lot of patients with TB, they're all daily wage laborers, and spending a whole day in a clinic affects their ability to earn. So we are trying to find out if an interval, just let's say 4 to 8 hours, predicts serum thresholds the best. We can just schedule their clinic visit 4 hours after they take the medication, or towards the end of the day, maybe after 8 hours after they take the medication, and then just have them bring a container of urine collected between 4 and 8 hours to the clinic, and then we can just test and find out if they're adequately dosed. So here are the results of just a preliminary analysis of the adult population, and then so far it seems like the 0 to 4 hour collection interval predicts relevant serum rifampin target in adults. So with that, I'd like to thank my team and our collaborators in New Jersey and Tanzania who have been instrumental in this study. Thank you.